Hi, I'm Angie Davis. I'm the president of Fight Colorectal Cancer, and I'm so glad you're here at our headquarters here in Springfield, Missouri to have a conversation about our path to a cure and what we're gonna do to break walls, break boxes, and do different things than what is the status quo. And I think that today we're just gonna have a conversation with each other and talk about what are those priorities? What could we do as it relates to screening and treatment and changing policy? So thank you for joining us today, and I'm looking forward to hearing what you have to say. So we're gonna just start with an initial prompt and have a conversation. Everyone just feel free to jump in. But what do you think the biggest barrier is to finding a cure for colorectal cancer?
I think it's a really important question because this is a cancer that's affecting too many people. It's the #2 cancer killer, and it doesn't need to be because we can prevent it in many cases, which I'm sure we'll talk about. But when we talk about cure, I think there's a lot of problems. I think there's a lot of reasons why we haven't yet unlocked that box and gotten to a cure for colorectal cancer. We haven't in this country found a way to centralize the data or to provide all of the experts with the data that they need to do the science effectively and efficiently to get the answers that we need to solve this problem and to prevent people from dying from this disease.
Chris, what do you think?
I think that's exactly right. I think actually the questions that we ask determine the answers that we can come up with. And to date, we have asked very not interesting questions. So far, we treat colorectal cancer as if it's all one disease, and it is clearly not. And we have all of the molecular tools we could possibly need to get more insight into the various subtypes of this disease, and yet have not seen that become part of the standard of care in this country. And I think that's the biggest impedance we have at this point.
Winora, what does cure mean for you? What does this mean, this path to a cure?
A path for a cure would mean that I wouldn't have to feel like I'm suffering from PTSD of wondering if I'm going to have a recurrence. Or am I just going to have to stay with the standard form of treatment that's been given, chemotherapy or radiation? I don't want that. So for me, a path for a cure means that I have a better quality of life versus quantity of life,
So few patients take part in clinical trials, and there are myriad reasons for that, but it's probably less than 5% of all cancer patients are taking part in enrolling in clinical trials. And then there's 95% of patients who we're not learning from at all. So my passion involves learning from the experience of every cancer patient, whether or not they take part in clinical trials. And what can we learn from the real world data of patients that are more representative of the cancer patients, the colon cancer patients we see in our office every day, who tend to be older, not as well off, not as, with more other diseases going on, diabetes, high blood pressure, heart disease, than the patients who enroll in clinical trials who are healthier in a lot of ways than the patients who walk into our office every day.
I'm going to challenge all of you oncologists here. I'll be blunt. The perception from the patient side is you don't want the sick patients in your clinical trials. You want the well patients in your trials. And I think that's sometimes, frankly, demoralizing to patients. And the way that you have to get into clinical trials is, I'm a physician, and I struggled with getting John into clinical trials. It was a part-time job for me. And so, Mrs. Jones, who is, 64 years old, who lives in Nebraska, has no access to any of this. And it's crazy. It makes no sense to me why you have to live in a major medical center, and all I'm saying to people is make sure you're at an NCI designated center so you have access to trials. And then the patients have to push. Why can't I get in a trial? Why can't I get into a trial? I understand standard of care, but the standard of care isn't good enough anymore. And we have to stop that thinking around you have to do this, then you have to do this, and then you have to do this. Because the only way we're going to fix it is if we start zigzagging.
Yeah, I think you're so right. And we have to do a better job normalizing the idea that clinical care and clinical research are part of a continuum. You don't go here to take part in research and have that opportunity, and you don't go here for routine clinical care. But clinical care and clinical research, or clinical research, the opportunity to take part in research and receive a new therapy, should be available everywhere that clinical care is delivered.
Could I follow up on something you
please.
said? Because as a primary care doctor, if you had a patient that was seeing you and you wanted to help them get into clinical trials, would there be a financially viable way to do that within your office structure?
So here's what happens. They say to me, and my patients sort of know my situation, and they say to me, hey, I'm in blah, blah, blah. And then we talk about their care. And then I say, well, have you thought about a clinical trial? No. And I've had a couple of patients with colorectal cancer. So, they're thrilled. They know, I know what we're talking about. And then I go to a clinic, honestly, the Fight Colorectal Cancer Clinical Trial Finder, I download it, and then I start to help them weed out what trials are options or not options. That's my own personal time.
And that's actually the point I was trying to make, is that right in the way medical reimbursement works today, there is no incentive for even a medical oncologist to refer a patient to a clinical trial. There's zero incentive. In fact, that is negative for your billing.
It's a disincentive, exactly.
So you're more incentivized to send somebody to surgery than you are to send somebody to a clinical trial.
And I have to say, my husband's oncologist was very generous with his time, because I would spend a lot of time, and then he would look at it and help me with the science, because that was the part I didn't necessarily have the depth of knowledge. Is it financially viable? I think it'd be very financially viable frankly, for payers to invest in a model like that. And, come talk to me, because I'll tell you how to do it.
But also there are very good practitioners in the community setting.
Oh, absolutely. And I don't want,
And I just want to make sure we clarify that. And as we all know, a lot of these practices are seeing multiple different types of patients of various malignancies. So they're not necessarily an expert in colorectal cancer, but they want to help the patient. And sometimes they just don't have the bandwidth to do so because they're so busy with their paperwork or other things that they cannot enroll a patient at their site per se, because maybe they don't have that capability. Because once again, we have the CROs that come in to audit trials, and that requires payment from pharma companies to those community settings. So that's why we are limited. But I fully support, I truthfully believe that there's an outreach issue for a lot of individuals, especially in remote areas. I think we've all seen that. Not everybody lives close to a big city, and we're very fortunate, I think, the majority of us. But access also is a big problem. So patient education.
Patients don't, and they don't know.
They
don't even know what to ask for.
Education and awareness is extremely
very
important.
And it's also trust, right?
Yes, I was going to
because
mention
you
that
can
next.
have the access, you can even have the information, but unless patients have trust that they're not going to be treated like a guinea pig, that they're actually going to potentially have access to better therapy and better care.
This is where communication comes in.
Exactly.
But it's not just the doctor to the patient or the patient to the doctor. It's both ways. For me, I tell people I have a great healthcare team. But you know why? It's because when I go in and they sincerely ask, Winora, how are you doing today? Well, my foot hurts really bad because I have neuropathy. Be honest with your doctor. Let them know what's really going on. And when you develop a really good dialogue and conversation going back and forth, that communication is there. So that when I do go in now, my doctor is like, Winora, this is something that I thought you would be interested in. I've become this patient advocate because I'm like, why are so many people dying? Why are so many people of color not knowing that a simple fit test could save their life?
You also have to realize that colorectal cancer is a disease we can prevent.
Yes.
Right.
And we're not doing a good job of it, okay? So in this country, there are very few cancers or diseases that we say everyone should be screened for, and colorectal cancer is one of them. But when you look at the data, only 2 out of 3 eligible people are screened. And when you look at, and certain states, when you look at certain populations, particularly vulnerable or marginalized populations, rural populations, racial and ethnic minority populations, those rates are even lower. So we look at the cancer spectrum from risk factors and prevention of disease all the way to survivorship. We are losing the battle in all of those categories.
And the population is growing.
Exactly.
So it dropped to 45. That puts about 43 million people eligible for screening. Prior to that, it was about 22 million, and we only had about 68% that were being screened.
Yeah. And that's an issue that we have to communicate, right, as a field, right? Is that it's this screening can save lives, but that when to start screening, and then also recognizing that it's not that colorectal cancer starts at the age of 45, right? We have many patients that we've all seen where this is happening earlier. So it's also about communication about what's going on with your body, being comfortable to share these things with your doctor. Seek out care sooner. And don't be satisfied with that first response if it just doesn't feel right for your body. And so I think that's a message that really can help.
And the stigma associated. The stigma for colorectal cancer more than any other cancer.
Or Angie, I never knew that colorectal cancer even ran in my family until I was diagnosed with it. And my aunt goes, yeah, by the way, your grandfather had colorectal cancer. He passed away from it. And all I could think was that was a 15-year difference of me being tested that had I known probably would have kept me from having a late stage cancer.
And it's so true. I've been in this industry for over 15 years. My father-in-law had 13 polyps, felt like he didn't need to share that. When I heard that he had polyps, I was like, how many? He goes, 13. I mean, what is that? So immediately had my husband screened, and now I'm very concerned that my son needs, you look down the generations, you're very concerned, not just about cancer, but polyps.
This is important because we say in the prevention world that family secrets kill. Because what's happening is that we're not passing this information along generationally. And your story, I've heard it a million times. I went home, I told my family members that I had a polyp, and suddenly uncles, auntie, everybody came out saying, oh yeah, I had him too. And no one had talked about it around the dinner table before that. So we really need to make sure, again, back to this cancer care continuum, that we're also educating people about familial risk and letting people know that when you have that family risk, you actually get screened earlier, and that's why that information is important to know.
Yeah, really interesting, because this is the 50th anniversary of the National Cancer Act of 1971, and I've been reflecting on, what are the changes that have taken place in those past 50 years, and there have been dramatic changes. One of them is what is the meaning of a cancer diagnosis to someone? When I started my career, which was not 50 years ago, but even a few decades ago when I started my career, many patients, it was a secret that they had a cancer diagnosis. They wouldn't share it with their families. It was very isolating for some folks. That's not the norm anymore. People are not associating a polyp with as a precancerous finding that bears on risk for their family members. And we, in the next 50 years, in the next 5 years, we need to do a lot better with that.
But it's a good point that you brought up, the Cancer Act. So sometimes we forget that was one woman who asked for funding for cancer. And she went to the federal government and got her member of Congress and said, we need millions of dollars for cancer. And not only that, she said, Congress can't tell them what to do because we need to find a cure for cancer. And I think it's really important to remember that advocacy was behind that. Where I do think we get lost is that it has to be still serving the patient. And so now we're not telling NCI what science they need to do. For sure, that's not our jobs. We're not experts as patients, but we know what we want. We know what kind of quality of life we want. We know that we want to have access to it. We want to live longer. But how can we continue to have that dialogue with NCI as advocacy organizations to say, we want to be partners with you in this fight against cancer?
One of the most important things Fight CRC has done for me is to educate me about policy, clinical trials, and genetic testing. I'm now empowered that I have the ability to go and sit on panels, hold a discussion, or be in the room. And that's all because Fight CRC has taken the time to say, this is so important that we're going to train individuals who normally don't even understand certain terms when it comes to science and medical terminology. that they are now, the fighters that they are. So I thank you for that.
Can I ask you a question? You mentioned earlier that you have Lynch syndrome, and thank you for sharing that information. How do we educate other patients that we know are at risk for Lynch syndrome and they are deferring genetic testing?
That's, again, what I say when it comes to patient awareness is that there's got to be some kind of way, whether it's the old-fashioned method of maybe a simple pamphlet of understanding of, we were trying to do a group think or a think tank too of how can we get patients to really realize the importance of that.
But I also
even
think
know that they're at risk. I mean, I have families that don't understand. No one's told them. And, and I'm, as a family doctor, I fortunately have generations in my practice, and I can wait a second, but what about this? And if you start to put together the pedigree, you realize, wait, there's something wrong here. And and no one has put it together. No one has made those connections.
And I think it's important then to mention that Lynch syndrome is just not colorectal cancer, right?
Right.
I've had colorectal cancer, endometrial cancer, basal cell carcinoma, and the first thing I thought as a person of color is I'm Black. I don't sit out in the sun. Why do I have skin cancer? Right? But it's this additional, it's Lynch syndrome.
But I think the idea to be proactive as a patient to get this testing done certainly applies to familial syndromes and really understanding that. So there's still large numbers of patients that just don't even have the very basic biomarker testing done to help guide their disease. So that's a huge barrier.
They don't know they need to have it done, and I think we have a gap, frankly, on the oncologist side. I mean, when I hear people say to me, "Well, my oncologist didn't recommend it right now," my answer is, well, that's standard of care.
I go get genetic testing. I'm confirmed now as Lynch syndrome. I can't even get basic life insurance.
That's true.
So now the genie, let's say, is out of the bottle. And now while I'm living a good life, I have no evidence of disease now, but my life is still hampered because I can't get simple things such as
No, I think that's true.
insurance.
And misinformation too around genetic testing and even biomarker testing. I think a lot of patients think that it's a scarlet letter. If I get the test, then my insurance will be a higher premium, or it'll be harder for me to, have transportable insurance if I move or I move jobs. And so there's just a life issue, and that's a policy issue, which I think is something that we can tackle. And I think that, and you've spoken about early age onset, and even from screening with early age onset and treatment of early age onset patients, that becomes a real issue because they have a lot of life to live and a lot of things that need to get done. And candidly, I think sometimes physicians don't spend enough time with early age onset patients around fertility, sexuality, all those things that come with it that are very unique and different for patients that are dealing with colorectal cancer, and for our early age onset patients who present with symptoms. And are told that, they
have hemorrhoids.
Yeah, they're told that all the time, and that is a teaching of the past. We used to teach that if you have rectal bleeding, it's probably hemorrhoids. Probably don't need to do much about it; it will go away. But we're not teaching that to our trainees anymore. We're teaching them that regardless of the patient's age, you need to investigate it with the colonoscopy because it could be cancer. We're seeing rectal cancers. We're seeing colon cancers in 30 and 40-year-olds. So it is policy, and it's patient advocacy, right, to cover these topics that aren't covered by the provider. It's provider education to make sure we're taking care of patients appropriately as well.
The sentiment is urgency. Where is that urgency? And I'd love to hear from you all. How can we continue to spark that urgency, not just with the people that we attract, but the people outside of our group, the people that really need to engage, and we need to win them over, that this has to be a national priority.
Data and stories,
Yes.
are two big reasons. And you've done a great job of that in the way you convene stakeholders together to put patients telling their stories side by side with scientists and clinicians and policymakers and advocates and folks from industry who are developing new therapies and new diagnostics. And by focusing everybody, and really focus is sort of the operative word for me, focusing everybody on the end game, which is a shared goal for all of us, which is the patient, is I think the way to sort of get traction and move the needle. Because when, even those of us who either are or in the past had taken care of patients on a day-to-day basis, and we're faced with patient stories every single day, it's somehow different when you're in the office focused on the okay, what are we going to do next? What tests do we have to do? What treatment do we have to do? Versus in another setting where you're just hearing the story, how this happened to me, how this affected my life, and how my hopes and dreams have been changed by my diagnosis. That's really powerful.
I think also touching the future patient, because they're coming. Right. We can't stop that yet. So with the social media that you're using, getting the word out there, because when I have someone that comes to me and as a patient advocate and they say, I've just been diagnosed, or I have a family member or someone has just been diagnosed, I'm reaching for those resources that I know that are there. I'm going straight to the website, I'm pulling from the website, and it's so much easier to have than the old-fashioned method of, I'll mail you something and it'll get to you. But just having all of that information accessible, and like you said, those stories.
And, when I first started out my career, I noticed this early onset, very, very early on, but then everyone thought that maybe it was just a bit biased because I worked at a large referral center. But it was time and time again seen repeatedly presented with late stage disease because more often than not, they were either misdiagnosed or misinformed or did not have a primary care physician, often with the diagnosis of hemorrhoids or irritable bowel disease.
Right.
And I said, who told you you had irritable bowel disease? Well, that's what they just told me. I said, were you tested? Or inflammatory bowel disease, and where does this diagnosis from?
From a primary care physician perspective, I think the prevention is so important, and the message around, and I say to everybody, if you're 45 and you have a colon, you need to be screened. I mean, it's pretty simple at this point. So aligning up the incentives, as a primary care physician, quality metrics are really important to my organization and I'm sure to across the country. Let's align the incentives. Let's make it attractive for family doctors, primary care doctors to get their patients screened, whatever it takes.
Back to what you were saying earlier about energizing the masses, the people who are to come to, unfortunately, will have this diagnosis unless they get prevention. Because the key to getting those people informed is informing them about screening, right? And we've done that in some populations better than we have in others. We know that we underscreen African Americans. We know that we underscreen Latinos in this country, Native American, American Indian, Alaska Natives. So those are populations that we also need to message to that you are getting this disease as well. In some cases, you're more likely to die from this disease, especially when you talk about American Indians and Black Americans. But there's something that you can do. And if you do it, it matters, right? Because we have the data that says that if we diagnose colorectal cancer at stage 1, your survival is 90%. If we don't diagnose it till stage 4, your survival drops to the teens, 13, 15%.
This line of thinking is really exciting because there's a conversation around education, which is super important, but there's also a conversation here around systems and practices and how we align incentives with what is actually best for all of us and individuals. And there is a meeting point there that is obvious. And one of them, like you said, if it is actually cost effective for the entire country to have all of us screened, which it is, then we should incentivize. We should incentivize physicians to make sure it happens. We should incentivize patients. How do we do that? We could lower the cost of insurance premiums for people who have their screening. Nothing matters more to me than losing $200. Now, if you give me $200, maybe, but if you're taking it from me, then I'll go, so that actually matters to people. And there are economic principles that tell us how to fix these things. What we've done as a country is failed to create a system that incentivizes wellness. We worry about how to fix a problem after it happens, and we don't try to prevent it.
Well, I just want to thank you all for this amazing conversation because you are the faces of champions and what we're going to do together is going to be incredible. And Path to a Cure will be starting today, but we've got a long road, but it's an exciting one. I just know we're going to change the world. So thank you for being with us.
Thank you for
Thank you, Fight CRC.
Yeah.